joined in already. We're still expecting a few more. We could just give 1 or 2 minutes for just to allow a few more people to join in. I know it's morning in the US. It's mid-afternoon here in Nigeria, but we are so happy to have everyone around.
Good morning, Dr. Grande.
Good morning, Uche.
Thanks for joining us.
Thanks for the opportunity. Nice to see you.
Yeah. I'm trying to put on my...
Give it a few more minutes for people to join in.
Yeah, no problem. Just getting my computer monitors all set up here.
Yeah, it's a bit dark.
Is everybody hearing me?
Oh, she's about. Yeah, we can see it. Yeah.
Can you hear me too?
Yes. I think your audio is good.
Yes, we can.
Morning, everybody.
Morning.
Good morning. I think. Okay. So I think we just start. I'm delighted to welcome everyone to today's Grand Rounds. Thank you everyone for joining us. My name is Dr. Femi Bankole. I'm an associate professor and chief of neurosurgery at the Lagos University Teaching Hospital. We have several stakeholders here with us from various parts of the world joining us today. We have, including neurosurgeons, radiologists, neurologists. We have some of our nurses and technologists as well in LUTH and in our partner institutions. We've been trying to hold these grand rounds for about bi-monthly over the last year or so. The title of today's grand rounds is Endovascular Treatment of Subdural Hematoma. And that promises to be quite exciting, and I'm looking forward to hearing that myself. Before I introduce our moderator and presenter for today, I would like to give a few housekeeping tips. We'll ask that as we join, please mute your microphone unless you called upon to speak by the moderator or presenter. And when sharing a video, be mindful of what's in your background. We sometimes experience a few technological hiccups, but just bear with us, we will surely overcome. We'll have opportunity to ask questions after the presentation, so you can, during the session, if you have a question, you can put it in the chat box, and the moderator will read your question to the presenter during the Q&A session. Additionally, if you'd like to ask your question directly, then just use the hand raise feature in Zoom and you'll be invited to ask your question during the Q&A. So our moderator today is Dr. Chizoba Ezepu, MD. Dr. Ezepu practices as a specialist in vascular neurology and neuroendovascular surgery at the SSM Health Systems in St. Louis, Missouri, United States. He's board certified in neurology and vascular neurology. Dr. Ezepu attended medical school at Nnamdi Azikiwe University in Nigeria. He completed his residency in adult neurology at the Medical College of Georgia in Augusta, Georgia, and followed that by fellowship training in vascular neurology and neuroendovascular surgery at the St. Louis University. Today's presenter is Dr. Andrew Grande. He's a board certified neurosurgeon at the mHealth Fairview Clinics and Surgery Center, Minneapolis. He's also associate professor and co-director, stroke, brain injury, and stem cell lab faculty, and associate director of the Residency Program of the Department of Surgery at the University of Minnesota Department of Neurosurgery. Dr. Grande graduated from the St. Olaf College, Northfield, Minnesota, with a BA in chemistry, and he then attended the University of Minnesota Medical School. He completed his neurosurgery training at the Mayfield Clinic and University of Cincinnati. He then went on to complete a fellowship at the University of Cincinnati in both endovascular and cerebrovascular neurosurgery. His clinical interests include hemifacial spasm, intracranial and extracranial stenosis, moyamoya disease, skull-based surgery, stem cells, and the treatment of stroke and trigeminal neuralgia. His research interest is focused on translating stem cell therapies for stroke from the bench to the bedside. In 2010, Dr. Grande was the recipient of the William P. Van Wagenen Fellowship from the American Association of Neurological Surgeons. So without taking much more time, I'd like to hand over to Dr. Grande for his presentation. It's over to you, Dr. Grande.
All right. Well, can everybody hear me all right? All right.
Yes, we can.
Perfect. Well, thanks for the opportunity. This is really special. You had mentioned that I went to college at St. Olaf College, and St. Olaf is well known for its international abroad programs. And so while I was there, I spent 6 months abroad in the Middle East and Asia for the most part, and really acquired an appreciation for international travel and an appreciation for international relationships. I've always found that international relationships they seem to be stronger than sometimes domestic relationships. And so I've always appreciated that. And then I did the Van Wagenen Fellowship where I traveled to Germany for a year, and during that year, tried to travel around primarily Europe as much as I could to interact and learn from neurosurgeons there. And one of the things that I came to appreciate both from that trip and then also through my training in Cincinnati, where we had a lot of international fellows, was appreciating the role that international neurosurgery plays in the world. And so I really have a lot of respect and appreciation for international neurosurgery. And I think it was through that Uche came and worked with me in our neuroanatomy lab, and then stayed on and was a neurointerventional fellow, and has been a great friend and colleague, and has done tremendous work. So a lot for you guys to be proud of. But I've really appreciated that friendship and connection, which I think led to this. With that in mind, I just would like to take the opportunity to, for this group, if others want to come to the University of Minnesota to observe, or if you have trainees that want to come we have a neuroanatomy fellowship set up for international neurosurgeons to come and spend anywhere from 6 months to 2 years. Would love to, extend an invitation to people. So without further ado, I was asked to talk about an emerging concept. Actually, let me first share my screen, and then I will start the presentation here. So I have this set up so that hopefully this will play. So are you guys seeing just the single slide at this point? Uche,
No, we can't see your slides yet. You want to share your screen?
I'm sharing the screen right now. What do you guys see on your screen?
It's just you still speaking.
Just yourself.
Huh?
Just yourself speaking. We haven't really started seeing the screen.
Oh, really? Okay. Let's see what happens here. Now what do you see? Same thing?
Yeah. Yeah,
And
you
now?
still.
Just me. All right, let's try it again. I would like to share. All right. Do you see a desktop now?
There you
Yes.
go.
All right. You see a mountain desktop?
Yes.
All right. And then get this all. Now do you see a slide?
That's correct.
Now you see the slide, the title
Yes.
slide.
Yes, we do.
Awesome. So I was asked to discuss the topic of middle meningeal artery embolization for chronic subdural hematoma. Just so I can get a sense of the audience, how many people here do neurointervention? Is there just a few or? Okay. So most people are neurosurgeons, but not doing neurointervention. Would that be an accurate statement?
Yes, that would be correct.
Okay, perfect. All right, perfect. So I've been asked to talk about middle meningeal artery embolization for chronic subdural hematoma. So I have a moderate number of slides here, not an excessive number. And so this is kind of set up with the idea of for you guys to please feel free to interrupt and interact and ask questions. I think this is a provocative topic. Or in the past, I think it was pretty provocative, and now it's becoming a little bit more of a mainstream therapy, at least here in the United States. These are the disclosures that I have. I do some speaking for Medtronic and Integra and research support from hog strike microscopes. None of this should impact the conversation today. So again, the topic for today is the treatment of chronic subdural hematomas. And, as a resident, I never was real excited about the treatment of chronic subdural hematomas. It wasn't the sexy part of neurosurgery. It wasn't the most complex part of neurosurgery. These are the cases that we would always give to the junior resident. And I think we underestimated the complications that can arise and underestimated the impact that this has on patients' lives. And we oftentimes would associate a bad outcome with the disease and not with our treatment strategy per se. We didn't blame ourselves when I think the reality of it is there was an opportunity at that point in time to understand this disease better and to treat it better. And I'll get into that a little bit. So the incidence is quite high. The incidence is 14 patients per 100,000. Over the next 15 years, I think this incidence is expected to double. We have an aging population. That population is increasingly on anticoagulation. And so I think that the incidence here is expected to rise. This is a problem that is becoming more prevalent. So the reality of it is that you have an acute subdural hematoma, and this acute subdural hematoma oftentimes progresses to a chronic subdural hematoma. And at least my teaching for this was the following. It was that in the acute setting, you had this dense clot. And what would happen is that there would be fluid migration from the brain into the clot because of osmosis. And here I have a picture of osmosis where you had a higher concentration in the clot than in the tissue. And so fluid would migrate from the brain parenchyma into the subdural hematoma, and you'd have expansion of a subdural hematoma. At least that's what I was taught as to why over time subdural hematomas enlarge. And I would suspect that there are still an awful lot of neurosurgeons in the United States who probably believe in this hypothesis as it relates to subdural hematomas. And this hypothesis is important because it impacts how we manage subdural hematomas. The idea here was to evacuate that concentrated fluid that was in the subdural space. And if you relieved that concentrated fluid and replaced it with saline, you no longer had osmosis occurring, and over time that subdural hematoma would go away. And so there are many here who practice when there's an acute subdural hematoma to let it liquefy and then perform a minimally invasive burr hole to evacuate the fluid, and the subdural would go away. So historically, as far as treatment, these are kind of the three treatment options here in the United States. There's craniotomy, which we oftentimes will use for an acute subdural hematoma. And then when that acute subdural hematoma becomes chronic, either a twist drill at the bedside for evacuating it, or 1 or 2 burr holes and then letting the fluid escape. In my own practice, if a patient comes in, especially a young patient, traumatic subdural hematoma, significant shift, I'll do a craniotomy and evacuate that acute subdural hematoma, which is life-saving. If it doesn't require that, then I may wait 1 or 2 weeks until it liquefies. I tend to use a small craniotomy rather than burr holes. I'll make a craniotomy that is bigger than a silver dollar, smaller than a sand dollar that you find on the beach. And then I put 2 drains in, and I evacuate the fluid. I do the kind of cookie cutter craniotomy rather than the burr holes because of the potential for adhesions or membranes. I find that it's safer to do that. I can deal with the membranes if I need to, and I can place drains under direct observation. So I feel more comfortable with a small craniotomy, and I don't feel like I'm losing much in comparison to the burr holes. I put 2 drains in with the idea that there are patients who will pull a drain. I still at least have a backup in place. So that's my practice, or has been my practice up until more recently. Now, in preparing for this talk, I was actually pretty surprised by some of the numbers that are reported with regards to this type of treatment. So in the classic management of chronic subdural hematomas, the recurrence rates are anywhere from 5 to 37%. Repeat procedures within 30 days, 5 to 10%. I've even seen up to 30%. And I would say that that correlates pretty well with my own practice. This one's surprising. In the kind of current management, mortality rate at 1 year is up to 30% with chronic subdural hematomas. And I bring back up a comment I made at the beginning as it relates to how we approach subdural hematomas. We kind of poo-poo them. We think that this is not a complex neurosurgical procedure, not a sexy neurosurgical procedure. We oftentimes give this to the junior resident or the junior faculty to take care of. Yet you have a disease with a mortality rate of up to 30%, recurrence rates of up to 37%. I would subject to you that we can do better than that. Those are pretty terrible numbers. And so the reality of it is, do we really understand this disease or not? And I think, beginning in 2000, so over the last 20 years, there's been a new hypothesis that's been suggested as it relates to chronic subdural hematomas. And so that hypothesis is that a subdural forms, and it will form in the subdural space. And oftentimes there's two layers, and you have an external and an internal membrane. You've got this cascade of a clot forming and then clot being broken down with plasmin, plasminogen, fibrinolysis. And that then kicks off an inflammatory cascade. And this is a complex slide, but I think what's really important to understand is you have this inflammatory cascade that is kicked off with neutrophils, lymphocytes, macrophages being recruited to the area. This is due to an increase in IL-6, IL-8. And then because of the neutrophils, lymphocytes, macrophages, eventually it leads to an increase in VEGF. And with that increase in VEGF, you have neovascularization that occurs, and this leads to the membrane formation. And you now have increased blood supply, and these blood capillaries that are formed are felt to be somewhat friable and are prone to rupture. And then this leads to a cascade that snowballs. And so with this in mind, people have theorized, and there's been some studies, that maybe we should be treating these patients with corticosteroids to inhibit the inflammation, or antifibrinolytics, statin drugs, or angiotensin converting enzyme inhibitors. And the whole idea with these medication, this medication approach or therapy for subdural hematoma is to somehow interrupt this cascade that is occurring. There have been some clinical trials. I'm not going to get into them. I think the results from these clinical trials using corticosteroids and statins have been, they've resulted in mixed findings. Recognizing that there is this neovascularization that occurs, there was a Japanese group in 2000 that asked the question, could we embolize these blood vessels that innervate the membrane? And in particular, it's the middle meningeal artery. And so this is a publication from 2000. This is the first publication ever for embolization of chronic subdural hematoma from Japan. And so in the bottom right of the paper, you can see that this is a patient that presented with an acute subdural hematoma. It was evacuated through standard surgical treatment. However, it recurred. And they performed an angiogram, and in the right, figure 3 there shows their angiogram, and you can see the middle meningeal artery. And as the middle meningeal artery climbs up and branches, you can almost see this clouding effect. And I think this very nicely depicts the neovascularization that has occurred, or these blood vessels that have sprouted from the middle meningeal artery. And so they theorized that they could embolize the middle meningeal artery and cut off this blood flow, and sure enough, they did, and they found that there was resolution of the subdural. So this was in 2000. Following this, then there were some other anecdotal experiences here in the United States. And I remember going to either the Congress of Neurosurgeons meeting, or it was the American Association of Neurologic Surgeons meeting. And there was a presentation about MMA embolization for subdural hematoma. And it was eye-opening. I remember listening to it, and there was really nice results that were presented, but I was pretty skeptical, as were a number of my colleagues. However, it really did start to introduce the idea of, should we be embolizing subdural hematomas? it also brings up an interesting point. In our neurosurgical space, are randomized controlled trials required before we embark on new innovative therapies? And this proved to me that we as neurosurgeons and neurointerventionalists do not require those randomized controlled double-blinded studies before we embark on a new therapy, because following that presentation at either the CNS or the AANS, my colleagues around the country started embolizing subdural hematomas, and were surprised by the results that they encountered. They actually had really nice resolution of subdural hematomas, as was presented, and people really started to wonder, is there something to this? And I think it was at that point in time that people also started to recognize that maybe our old hypothesis of why chronic subdural hematomas form was probably not correct. And maybe, in fact, this newer idea, maybe there was something to it. So that really introduced this new era of MMA embolization. I would say that this was somewhere around 2013 when people started to explore the use of embolization for the middle meningeal artery. And so in this picture here, and I can't remember which article this is from, this demonstrates an angiogram through the external carotid artery with a microcatheter positioned proximally in the MMA. And you can see the anterior and the posterior branches here. And the arrows are showing small wisps of blood vessels that are permeating the membrane of a subdural hematoma. And so as people began embolizing, they began embolizing with a variety of materials. I'd say early on, the majority of people were using particle for their embolization. Here's the contour particles that we use in the United States. I think people felt very comfortable with that. Now, I would say that one of the downsides with particles, particles are not expected to be a permanent embolization. Over time, they wash away. Alternatively, there's TrueFill or NBCA glue. That's been around for a long time. Ironically, in the United States, I would say that my generation of neurointerventionalists do not have as much experience with TrueFill or NBCA as previous generations. And that's because of Onyx. When I trained, we would use Onyx for all of our embolizations. And so I think my era and subsequent generations of neurointerventionalists have a lot of comfort with Onyx and perhaps not as comfort with NBCA. But the reality is, at this point in time, people are using either Onyx, TrueFill, or particle for embolization of the middle meningeal artery for the treatment of chronic subdural hematomas. And as you'll see, I think people find success with all three of these. But it does beg a question, and I'll bring this up later: is there an optimal treatment? Which of these is best? Which of these should we be using? Before I get to that, though, I want to show a couple meta-analysis. So this is a meta-analysis by a very good friend of mine, Peter Kahn. Peter's down south. He's chairman of Neurosurgery. And Peter's really done some nice work around MMA embolization, and it really began with this systematic review that he published in 2018. So in this systematic review, they found 3 double-arm studies that met their inclusion criteria, and these compared embolization versus surgery. Now, one of the things I would point out is that the embolization group was a mixed group. Some of these patients were treated with embolization alone. Some were treated with embolization immediately after burr hole or a craniotomy, and some were treated with embolization after failed surgery or recurrence. They also found 6 single-arm series in which they just treated with embolization in, again, a variety of different situations, but they did not compare to a surgical arm in those single-arm studies. What they found was pretty compelling. So the hematoma recurrence rate with embolization, and again, there are a variety of different scenarios for embolization, but nonetheless, the hematoma recurrence rate with embolization was around 2.1% in comparison to, in these studies, patients treated with just surgery, the recurrence rate was 27.7%. So I think that's pretty compelling that, number one, the embolization was not leading to a higher recurrence rate, but rather it seems that embolization does decrease the recurrence rate of chronic subdural hematomas. And they found statistically very comparable complication rates. With embolization, it was 2.1%. With surgery, it was 4.4%. So this study was published in 2018. More recently, Dale Ding, who he was a fellow with Michael Lawton down at Barrow. He's now out on his own. Dale Ding did this review, systematic review, that compared patients up to 2020. And in their review, there were 20 studies that composed of over 1,000 patients. It was 1,416 patients. 718 of those underwent MMA embolization, and 698 went conventional management. What's interesting, just to begin with, that I want to point out, is in Peter's study, which was published in 2018, they were looking at 9 studies. Now, when you expand this to 2020, Dale Ding's looking at 20 studies. So you can see this explosion of the use of MMA embolization for subdural hematomas, even despite not having any randomized double-blinded controlled study per se. And I think a lot of this is driven by the anecdotal experience of my colleagues around the country. I think people are finding that they were having good success with MMA embolization. Number one, they were finding it was safe, there was low complication rates, and anecdotally, they were, I think, surprised by their results. Anyhow, in Dale Ding's study, the MMA, so with MMA embolization, the recurrence, the surgical rescue, and complication rates were 4.8% for recurrence, 4.4% for surgical rescue, and complications in 1.7% of the cases. Compared to surgical treatment alone, the recurrence rate was 21.5%. So you're comparing 4.8% recurrence with MMA embolization to 21.5% recurrence with surgical evacuation, surgical rescue in 16.4%, and then complications in 4.9%. Again, I think if you look at the recurrence rate or the need for surgical rescue between these two treatments, I think the data, albeit it's a meta-analysis, is pretty compelling that we really should be considering MMA embolization. And we're probably at a point where a randomized controlled study is necessary. So I'd say, at this point, I think a few things have happened. So by 2020, I think at least my colleagues around the United States have really embraced MMA as a effective treatment for chronic subdural hematomas. I think they're finding that it's a relatively safe procedure. And, from a neurosurgical perspective, MMA embolization is relatively safe. It seems to have a good treatment effect. And the reality of it is, if it's failed, the treatment is taking the patient to the operating room for the surgery that we typically do anyhow. And so, in my practice, why not, with the chronic subdural hematoma, why not use MMA embolization up front? And hopefully you are treating the disease more effectively, you're avoiding surgery. And if all of that fails, you're back to what has been gold standard anyhow, which is burr hole evacuation or craniotomy. But some of the questions now that are starting to emerge for us that are doing this are the following. Should we be embolizing both the anterior and the posterior branch? Do we just need to embolize one of them? Should it be the anterior branch, the posterior branch? Does it matter? How far do we need to penetrate distally? So an interesting concept here is, if I'm going to do my surgery, let's say I do a craniotomy, should I coagulate the middle meningeal artery at the time of surgery? And by coagulating it, have I done the same thing that I would have achieved with an MMA embolization? Or is distal penetration of these neovascularized vessels necessary to have your treatment effect? And then what's the best material for success? Should I be using onyx, NBCA, particles? Does it really matter? These are some of the questions that I've had, and I think others have had as well. I've gone down to Barrow over the last couple of years a couple times, and I've gotten to know the group down there. And a guy that I really enjoy is Josh, who is the lead author on this paper here. And you'll see that Josh has done some nice studies here with actually not a lot of patients, but really elegant studies. So this is a publication that came out of Barrow with Philippe Albuquerque and Josh. And what they were looking at is their patient population between 2018 and 2019. They embolized 35 patients. This was 41 embolizations. So some of the patients had bilateral embolization. They used onyx in 72% of the cases, particles in 17, and NBCA in 12. Now, what was interesting is they found complete resolution when they embolized the anterior and posterior branch. They saw complete resolution in 76% of their patients. When they embolized just a single branch, they had complete resolution of 33% of their patients. Now, albeit they have a small number of cases, but this would suggest that it's important to embolize both the anterior and the posterior branch of the MMA, or embolizing the anterior and posterior has a greater chance of complete resolution. Josh followed this up with another really interesting study. And the question was, what is the duration of time after embolization in which you should expect resolution of the subdural? And keep in mind, this is a really important question as we proceed to ongoing clinical trials. So let's say we do our embolization. Should we expect that subdural to go away within a day, a week, a month, 60 days, 90 days, or 180 days? At what point do we determine that our treatment was a failure? This isn't working, it's not going away, and we need to do something differently. And so they look at their patients now between 2018 and 2020. They had 66 patients, 84 embolizations, and they looked at the effect of treatment on the subdural size at 30, 90, and 180 days. And they found that the mean chronic subdural size at those time points were 8.8, 3.4, and 1.0. Or in other words, they saw complete or near complete resolution of the subdural at 90 days in 63% of their patients. However, at 180 days, they saw complete resolution at 92 days. And this is important because there are anecdotal studies that have reported their success rate with embolization, but they've only looked at 30 or 90 days. And so you can see in Josh's study, if they had stopped at 90 days, they would say, well, MMA embolization results in complete or near complete resolution in only 63% of our patients. But what they found is that that chronic subdural hematoma continues to shrink and eventually go away. And so perhaps a 90-day outcome is too early for assessing success of our patients. And maybe what we should be doing is really following these patients out to 180 days to assess treatment effect. The other thing that they did is they did a univariate and also a multivariate analysis of a variety of variables. And in their multivariate analysis, they found that only distal embolization penetration was independently associated with rapid clearance. So I think that what this says is that getting your emboli distal is important for rapid clearance of the subdural. And I don't have their other paper up here, but they actually have a newer paper out that demonstrates that they have patients in which they've done a CAT scan immediately prior to embolization and immediately after embolization. And in many of these patients, the midline shift actually decreases immediately after embolization, which for me blows my mind. And to really understand the pathophysiology of that one. But they have demonstrated now that immediately after embolization, there is some reduction in that midline shift. So it sounds like, even though this is a small study, distal penetration is important, as is embolizing both the anterior and the posterior branch of the MMA. And I think that's where now you can start to think about your embolic material. And, you know, I think you need to look at your own experiences to appreciate in which setting do you get the greatest distal embolization. In my practice, I typically will use a Scepter mini balloon. I bring the Scepter mini balloon up into the STA, into the MMA. And then I inject onyx, and I want to get as distal penetration as possible. I've done this because I'm most comfortable with onyx. However, I have now on a few occasions used NBCA, and I find that it's easier to get distal penetration with NBCA. So I wonder, in the long run, will NBCA be a better material versus onyx? And I think this is where we do need to start looking at some of these trials that are coming on board. So there are some trials now that are ongoing. So Josh Osborne has a clinical trial comparing the change in chronic subdural size between upfront MMA embolization compared to surgery followed by MMA embolization versus surgery alone. And then Benitez has a clinical trial comparing MMA embolization alone versus surgical evacuation alone. In addition to that, there are some industry-sponsored trials. So there's the SQUID trial. SQUID trial or it's the STEM trial, which is SQUID trial. SQUID is a liquid embolic for the embolization of middle meningeal artery for the treatment of chronic subdurals. There's the EMBOLIZE trial, which is embolization of the middle meningeal artery with onyx liquid embolic system for subacute and chronic subdurals. And then there's now also the membrane trial, which is using NBCA. So I think these trials will start to give us some better sense of, should we just be treating these with MMA embolization up front? And what type of material should we be embolizing with? Lastly, I do think it's good to have some protocol. Who should we be embolizing? And so this is the protocol that Barrow has published. So they have 3 groups: observation, MMA embolization, and then surgical evacuation with or without MMA embolization. So in their protocol, if it's a small asymptomatic chronic subdural, less than 8 millimeters, they're going to observe, and they may or may not treat with corticosteroids or a statin. If there's a focal neurologic deficit, subdural is greater than 8 millimeters in size, with or without midline shift, they'll do MMA embolization. If it is a large subdural hematoma with midline shift that is greater than 5 millimeters, then they will do surgical evacuation with or without MMA embolization. Here at the University of Minnesota, I wouldn't say that we have a protocol in place, but our practice is that we are using MMA embolization as a standalone treatment for chronic subdurals. We have started to get a lot of consults for even patients in the acute setting. And I think it's important to go back to what is the pathophysiology of a chronic subdural hematoma? Why is it that MMA embolization actually is working? And is it effective in the acute setting? I think this is going to be a question to be asked down the road. But at least in my own practice, I'm not using MMA embolization in the acute setting. So if it's a hyperdense blood, I'm following the inclusion criteria for the membrane study, which is essentially if it is acute on chronic or chronic subdural, in which the chronic component is more than 50% of the subdural. If the chronic, or if the subdural is greater than 1 centimeter in size, if there is any midline shift and some focal neurologic deficit, then I am proceeding with MMA embolization. My approach to it, I will use either transfemoral or transradial approach, depending on the arch. When using transfemoral, I like to use a shuttle catheter. For my stability, I bring the shuttle catheter up, and then I use an envoy catheter. I don't feel that there's a need for an intermediate, so I use an envoy. I bring the envoy up into the external carotid artery. I then bring a scepter, mini balloon catheter, and I take that out into the STA. And I get up to the branch point of the anterior and posterior branch, and then I inject onyx. It's important when injecting onyx to recognize that you have DMSO, which can be painful. Ideally, I would do this with patients asleep. Anesthesia is sometimes difficult to schedule with. And so oftentimes, rather than waiting for anesthesia, I will bring these patients and do this under conscious sedation. When doing this with conscious sedation, it's important when using onyx to pre-inject with lidocaine. So I will pre-inject with roughly 4 or 5 cc's of lidocaine. And then I use the DMSO followed by onyx in those patients. If it is under general anesthesia, I'm just using DMSO followed by the onyx. And again, in some cases, I have now started using NBCA which I do think gives us better penetration. I'm still using the Scepter Mini Balloon when I do NBCA. It is important to understand that there can be complications with MMA embolization. And the complications to be cognizant of, the ophthalmic artery can be at risk. There are anatomic variants in which it is coming off of the MMA, and or the MMA is coming off the ophthalmic. And in those cases, if you have reflux of your embolic material, it can go out into the ophthalmic artery, and there are reports of patients that have developed blindness from this. I have seen presentations in which people have used high magnification for their injection, and what they have missed is when the embolic material goes outside of their field of view and comes back in through a collateral and actually then obstructs the ophthalmic artery and has led to blindness. It's important when doing this that you have the complete field in view on fluoroscopy. And it's important to understand that you have these collaterals that can go to the ophthalmic artery. In addition, proximally on the MMA, there are collaterals that give rise to blood flow to the facial nerve. And so if you are too far proximal on the MMA, you can also have a facial palsy as well. Those are two of the main complications that have arisen. In my practice, the only complication that I've had so far was a dissection of the left common carotid artery as it originated from the arch. This was not flow limiting, and so there was not a consequence of that complication other than we were not able to embolize. We aborted. Interestingly enough, that subdural went away on its own. The patient fell and has now presented with a subdural on the right side, which is chronic in nature and it's enlarging. And I very much would like to do an embolization. The family is very reluctant to have an embolization because of that complication that we had with their first subdural. So I would say that our complication has had an impact on the management of this patient. With that, I would like to open this up to questions or to dialogue around this idea of embolizing for the treatment of chronic subdural hematomas. Sure. And this, and I can pull up the chat as well.
Dr. Bankole, are you there?
What's that?
Oh, no, I'm calling on Dr. Bankole. It seems he's not there. So, but anyways, thank you, Dr. Grande, for such wonderful presentation. I mean, you summarized it so well that I don't see any question coming from the audience. It seems like all the questions that were prepared beforehand, you have systematically answered them all. But I want to use the opportunity to thank Dr. Bankole for all your hard work in advancing neurosurgery in Nigeria and for hosting these grand rounds. I'm very excited to be a part of this crucial initiative, and I'm grateful for the privilege to collaborate with all stakeholders, including the West Africa Stroke Initiative, in facilitating world-class comprehensive stroke care in Nigeria and other West African countries. Additional information will be provided in the future sessions, and we will also share opportunities for anyone interested in contributing to this much needed work. Dr. Grande, I also do MMA embolization myself. I don't do surgical, I just do neurointervention. And most of the times, what I have used now is radial approach. My setup, I don't know if it's the same with yours. I use this, depending on the diameter of the radial artery, I like to use the 6 French radial short sheath, and then I use benchmark. as my guide catheter. And then I pray that the patient has a good ECA stock, so I can just keep it there and hook it there and not have to worry about my catheter falling down. And I don't use intermediate catheter like you, but I don't have much experience using the Scepter Mini because I practice in a private setting and where cost is very you're in the United States, you know what that means. Cost is very important. So I use Apollo or the Echelon and or Marathon, anyone that we have on the shelf. I don't have preference one over the other. And during training as well, I'm only using Onyx, Onyx 18, because that's what I am trained with. The question I have, you have used enough. I think you're more experienced than I am, and I have used Onyx quite a lot. Have you ever experienced? There was one time I injected DM. You know how painful it is. All my cases I do under GA, general anesthesia. I injected DMSO, and the patient flatlined. Yeah, and we were about to jump on and start doing CPR when his heart kicked back off. It was just a DMSO. I have not had anyone, I've asked this question every time I hear a talk on, chronic subdural, hematoma embolization, whether anyone has had this experience before. Nobody has.
I have not had that experience. I mean, DMSO is a caustic compound. I mean, it actually, it's shocking to me that we're allowed to inject DMSO into the arteries. I'm absolutely shocked by it because it's a very caustic compound, but it is what it is. It is painful. We have had really good success with injecting lidocaine ahead of the DMSO.
Yeah, but you do that for when you are not using general anesthesia. You still do it anyways, even with
no. I just use it with conscious. I don't use it with general.
Yeah, this happened. Yeah, during general anesthesia. That's why it really. I asked the anesthesiologist, "You sure you didn't do anything?" He said, "No, we did something."
Yeah.
So, yeah.
Yeah, I mean, so I've also found, I mean, as far as flatlining too, I had a case where we did a embolization for an AVM in the posterior circulation. And so my catheter was out into the PCA. And when I went to remove the catheter was somewhat stuck, right? And so I had to pull with some force. And so as I pulled with the force on my catheter, the catheter came down the basilar and really compressed the brainstem. And that patient, we lost that patient flatlined. And then we initiated CPR and everything on that patient. I think the reality of it was we probably didn't need to initiate CPR. I think as soon as the catheter came out, I think everything went away. But the anesthesiologist saw that flatline and just jumped and didn't really wait to see if things would resolve. And then we went into this whole process that kind of kicked off a whole sequence of events of CPR and this, that, and the other. And maybe we didn't really need that whole sequence of events. I don't know.
I have more questions, but I have a Dr. Pastor Dele or Adewumi raise his hands. Please unmute yourself and ask your question.
Thank you very much. I'm actually a psychiatrist, and I don't really belong to this tribe of neurosurgeons. However, I'm interested in neuropsychiatry before I retired a few years ago. What I would like to know, thank you very much, first of all, Dr. Andrew, for this very interesting presentation. What I would like to know is about the long-term outcome, long-term neuropsychiatric outcome of these two methods of intervention. Is the intervention likely to be predictive of long-term neuropsychiatric prognosis? That's just my question. I do apologize for my lack of neurosurgical kind of knowledge, but I just felt this is an opportunity for me to kind of ask that question. Thank you very much.
Yeah. I don't know about the neuropsychiatric outcome. As I was preparing for this, I was surprised at the 1-year mortality with our conventional therapy as high as 35%. And I do attribute that to, that's with the craniotomies and burr holes. And, I can see how there can be a high mortality with some of these patients when there's recurrences, and then the patient's families elect to not have any additional treatment and whatnot. So my suspicion is that 1-year mortality with the MMA embolization, I think over time we're going to find that mortality rate with this treatment is going to be significantly lower. I don't know if anyone's looked at that yet, though.
Okay.
Yeah. Yeah. Sorry.
Go ahead.
Yeah. So when you talk about neuropsychiatric complications, most times, Dr. Grande told us that the population that suffers from chronic subdural age, we are getting an aging population. I think it's the same with back home in Nigeria. People are living longer. People are getting older. And the older we are, the propensity to develop dementia also is there. For people who are, like most people with chronic subdural hematoma also have other comorbidities. Like some of them have vascular dementia. So with or without SDH, they are already developing neuropsychiatric symptoms from their underlying dementia. Okay. Even when you talk about mortality, it's a controversial area, whether it is the subdural presence of the chronic subdural hematoma that is driving this high mortality, or their underlying medical problem. Because most of these older people have other things going on, and that's why when they say mortality rate is high, is it high because they also had chronic liver disease, or they had strokes, or they had cardiac issues going on that drives their mortality further, and also now have chronic subdural hematoma? Because most times the commonest cause is trauma. These people are frail, they have atrophy, in their brain, and they are more prone to have developed chronic subdural hematoma. Is this what's actually causing them to die, or their underlying problem? So it's hard to tell.
Okay. Yeah. Thank you. Thank you very much. Thank you.
And talking about Dr. Grande, okay, sorry. Someone else raised their hand. I don't want to take up for the Richard Olatunji, please. The floor is yours now.
Hello, everybody. Can you hear me?
Mm-hmm. Yes.
Yeah, I must say thank you so much to the West African Stroke Initiative team and the LUT team for sustaining these webinars. First, I'm Richard Olatunji. I'm a radiologist. So my background is radiology. I did fellowship in diagnostic neuroradiology and a stint in interventional neuroradiology in Toronto. So when Andrew was speaking, it just brought back the memories of my fellowship days. And one thing I want to particularly thank you for is the balance in your talk, the balance of the theoretical and the technical angles, and the literature. Everything made sense. And I want to especially tell you that one thing I picked that we never did was do MMMBO under local. But now I know it's possible with what you mentioned, and it's amazing. I'll also add that in our own kind of resource challenged practice back in Nigeria. I also noticed I can't help but understand that what you are comfortable with varies with generations. So I was a fellow under two different staff, different generations. One is comfortable pushing just coil to do MMMBO, and the other would use gel foam pledgets, and that's it. But with onyx, with particles, the results could be similar, but depends on who is doing what. I was waiting to hear if anybody had experience with stock catheter, microcatheter, while injecting onyx. Maybe that never happened, but the dissection you mentioned in the carotid, I know there was one for the MMA because of a stock catheter, microcatheter. So I believe the questions I wanted to ask, you answered a lot of it, but just in the context of where we are trying to use this knowledge, would you do these procedures under in a single plane?
Oh, yeah. Yeah, so that, it's interesting. So you talked about the people you trained with and the comfort level that they have doing different things, right? So I think that's a very astute comment. I trained in Cincinnati with Andy Ringer primarily. And in Cincinnati, we did all of our patients under local. We did not use general anesthesia for almost anything. And as a consequence, our patients, they moved more than probably other patients when they're under general anesthesia. But I became very comfortable with patients moving. I had another attending there who had trained under general anesthesia. He was very uncomfortable with any movement whatsoever. Similarly, in Cincinnati, at one of our hospitals, we had a monoplane. And during my training was an era where we were using HD 500 for the treatment of brain aneurysms. So I actually was involved in the largest case series probably ever published using HD 500. And almost every single one of those was done on a monoplane. And so I also became very comfortable with a monoplane. If you have people who have trained on a biplane, they almost think it's a sin to use just a monoplane. And so, I think the reality of it is, at least for me, I'm very comfortable using a monoplane. I'm very comfortable using local MAC and with a patient moving. And I don't see a problem with that. And so, I think if you look at kind of a resource strapped area, how do you do this procedure with limited resources? I think doing it on a monoplane is perfectly fine. I think doing this with a patient awake is also perfectly fine. You talk about the psychiatric long-term impact, right? So what's the long-term impact of general anesthesia in a patient that is in their late 80s or their 90s? Is there an impact with general anesthesia? So, should you be doing these under local MAC and avoiding the general anesthesia? Is that better for the patient? And so I think, I don't see a problem doing it with monoplane, local MAC. If I was to do that, I'm injecting lidocaine up front. As far as my catheter setup, I think I misspoke. I think I said I used a shuttle. Oftentimes I'll actually just go up with an envoy. So, I think the cheapest way to do this is you do a transfemoral approach. You get a 6 French sheath in there and then take up a 6 French envoy. I think an envoy DA catheter is probably one of the cheapest catheters that we use. Go up with an envoy DA and then, take a Prowler Plus. It has to be DMSO compatible, but look for a DMSO compatible microcatheter, whether or not it's a Headway 21, Headway Duo. You don't have to use a mini scepter, and then just wedge that into the STA. And then as far as your embolic, I don't know what's cheaper between NBCA or Onyx. However, one of the benefits of NBCA is with NBCA, you can inject your glue. And then I believe you can actually inject D5 follow it with D5 and wash out the catheter, and now pull the catheter back, and you can use that same catheter to access the posterior branch and inject NBCA out into that. If you're using Onyx, you have to use 2 microcatheters for Onyx, one for the anterior, one for the posterior. So, there may be if resources are an issue, just go up with an Envoy catheter, microcatheter, like a Prowler Plus, inject NBCA into the anterior, flush it with with D5, pull it back and go into the posterior branch and inject NBCA there. That may be the easiest way to do it on a monoplane, and that's probably the cheapest way to do it as well.
Yeah, I have another question here. He also talked about if you've had experience with the tip of the catheter getting lost. I think that's probably what Medtronic was thinking when they had the detachable tip Apollo catheter.
Yeah, that's a great question. So I'm in this procedure, I'm pretty careful with how much reflux I allow. So first of all, I don't think we've proven that you have to have significant distal penetration. Again, I did mention Josh's study that with distal penetration, the resolution is faster, but I don't think it's been proven that you have to have that distal penetration. So if I'm injecting and I'm getting a lot of reflux, I'm going to stop because I don't have evidence that I have to really push that distal penetration. You're in the STA, or you're in the MMA, and you're far out in the MMA. So if you get it wedged and stuck in the MMA, I think you're going to have a hard time pulling it out. And so once I start to see any significant reflux, I stop. And that's with the mindset of, I think what I've just done is probably going to be sufficient. Again, if you look out to 180 days, I think that's probably going to be sufficient. If it has failed, my backup is a craniotomy or a burr hole, which, I think that's okay. This is a procedure in which I think we have to make sure to really minimize our complications. This is a good procedure as long as our complication rate is low. And so I try very hard to minimize that reflux. It does remind me of one other case that I did, which was an interesting case. I used a mini scepter balloon, and the scepter balloons are a compliant balloon. And so you have to be careful with compliant balloons because they do have a higher tendency to rupture a vessel in comparison to a non-compliant. And I have a perfect case example of where there was a weakening in the wall and you just get this bleb of the balloon that popped through the vessels. So if you do rupture the MMA, you now will create an epidural hematoma. You've got a catheter up there and you're ready to embolize, so it's very easy to pull your catheter back and then to embolize, but be cognizant. If you rupture that MMA, you're going to create an epidural hematoma on top of your subdural hematoma. So, in that case, you just have to pull it back and then embolize.
I have one last question here from Dr. Enzomo. He says, I think part of this question probably has been answered, but are there requirements for the geriatric population on who should be undergoing this procedure, considering the high mortality rates, especially for the developing countries?
Yeah, so and just so I understand the question correctly, so in the elderly population, who should be undergoing this procedure?
Given that there is high mortality rate, according to this.
Well, I think the high mortality rate is associated with our traditional therapy. I'm not sure we've been able to articulate the mortality rate with MMA embolization per se.
I think what he meant was mortality rate of chronic subdural hematoma.
Oh, yeah, okay. Yeah, you know, I think this is a pretty low risk procedure. And, you know, again, you can do this under local MAC. So, you know, you can take an elderly individual and do it under local MAC. And, you know, I think what you've seen here is it's very effective. And so, you know, in the elderly population, I would be, quite frankly, quite aggressive
Yes.
in doing MMA embolization if they meet, again, I think some minimal standards. So I think, you know, what you want to ensure is, number one, it's a chronic subdural. You know, I think that there's some mass effect associated with it. So, you know, let's say you want to go with the barrel criteria, say chronic subdural greater than 8 millimeters in thickness, maybe some midline shift, you know, do the MMA embolization. I think that that would be a very, very appropriate thing to do. And I think we're actually getting to the point where not doing something for these individuals is, you know, not consistent with standard of care.
All right. Thank you very much, Dr. Grande. I think we are looking at the time. At this juncture, I want to hand over back to Dr. Bankole. It's my pleasure to be able to moderate this today. Thank you.
Yeah, thank
right.
you.
Thank
And
you.
again, I would just emphasize, you know, if you guys have trainees that would benefit from coming to the US, talk to Uche. You know, we have a neuroanatomy fellowship. It's a GME accredited neuroanatomy fellowship. I don't have funding for it to pay people. That's the downside. But we pay for everything involved in the research. People can come, they can do neuroanatomic research in our lab. And at the same time, you know, they can come to the OR, they can come to the angio suite, observe. You know, we really welcome having international neurosurgeons coming here. We'd love to host people.
All right. Thank you so much, Dr. Grande. Thank you, Dr. Zippo, also for the fantastic presentation and the stimulating discussion after that. One area in which maybe from our perspective is also cost considerations, but I think Dr. Latiji talked a little bit about that. I guess when we begin to try and scale some of these things on our level, we'll be able to better contextualize that. Just like to, before we conclude today's session, acknowledge that we have quite a number of stakeholders, including very senior colleagues in neurosurgery practicing on this side. And I'm sure we've all heard different things that would stimulate further conversations. Our next grand round will take place on the 14th of February next year. We'll be sharing the flyer so we can have a look at that. And please feel free to invite your colleagues. And if you have ideas or topics that you'd like to be presented in future grand rounds, you can reach out to either Dr. Okafor or myself. The recordings for today's presentation and also previous recordings will be uploaded on the West African Stroke Initiative soon to be established YouTube channel. We apologize for not providing previous recordings to those who have requested already. But once the channel is up and running, you will be notified of that. So thank you all again for joining us. We hope that this session has been valuable, and we hope that you have a wonderful rest of the day, and Merry Christmas to everyone.
Can I just make one last comment? As I was just thinking about the resource strapped, you know, you guys are also in a position here to explore the use of this using C-arm. So, I mean, there may be hospitals there in Africa that don't have a biplane suite or a monoplane, but have a C-arm. You know, the reality of this is you're in the external carotid artery. And so, yeah, you know, if I was in a very resource limited area, I would explore the use of MMA embolization for chronic subdural hematoma using just C-arm. And you may be able to make a huge impact with really limited resources.
Okay, that's interesting. Dr. Olatunji, I'm sure you're on board. We will talk a bit about this as we go forward. All right, thank you again. Really excited to be there. Thanks so much. Thank you,
Take care.
everyone. Have
Bye
a
now.
great day. Bye.
Thank you so much. Thank you, everyone.